Hi, I'm Dr. Dominic King, sports medicine physician at the Cleveland Clinic, and we're going to talk about minimally invasive tenotomy for the gluteal and hamstring tendons. Some practice gathered procedure pearls, what my experience has been with this, and where we can help you on your journey to remove tendinosis and get your patients with gluteal and hamstring pain back to doing what they love. So from a patient selection standpoint, I think this is probably maybe more important in this area than any other area of the body. Making sure we're using the right treatment for the right patient is important in everything that we do. But to get a good outcome from gluteal and hamstring tendinopathy, you really got to take a good look because these are weight-bearing joints. So there's so many other things that can cause issues. For a lot of patients with things like calcific tendinopathy of the shoulder or tennis elbow, there's other conditions that can cause pain in those areas, but for the most part, you feel pretty confident when you're evaluating somebody with common extensor tendinopathy that unless they're having some posterior interosseous nerve issue, you know what you're treating. With the glute and the hamstrings, that can be different. So for patients who present with gluteal pain, and specifically noting that they have pain to their greater trochanteric area, lateral hip, what would have been diagnosed previously as trochanteric bursitis, which we know they probably do have bursitis, but it's probably because of an underlying tendinopathy issue. Gluteal atrophy is really a major piece that can cause a ton of pain. So having a good diagnostic ultrasound evaluation of the muscle, doing good muscle testing in the office to know how much atrophy they have is important. Hip osteoarthritis obviously can be a big confounder there, even though most people will have it to their groin. Plenty of people can have a lot of lateral pain, and you might be going through a procedure when the patient may need more aimed at their osteoarthritis. Lumbar radiculopathy of multiple levels can cross right over the side of the hip. And the gluteal muscle, the gluteus max specifically, forming a scar between itself and the piriformis and potentially tethering or scarring the sciatic nerve is a condition that ourselves as sports medicine physicians, PM&R docs, and musculoskeletal interventional radiologists are understanding more and more, which does respond well to hydrodissection, but you have to look at it separately from gluteal tendinopathy. Same thing with the hamstring. I would say where I've gotten tricked more times than not until I had a better algorithm for how to evaluate it was ischiofemoral impingement. It's such a close cousin to the hamstring. Hamstring significant tendinosis itself can contribute to that condition. So I want to speak a couple slides on how to differentiate that from hamstring tendinosis specifically. And again, the gluteal piriformis sciatic nerve can, especially if the sciatic nerve gets tethered, patients getting more posterior pain. How much of that is the hamstring? You get an ultrasound, you see the hamstring looks like it has significant tendinosis. That's where you want to have a little bit of a patient pause before jumping right into TenJet and making sure that you've ruled out some of these other conditions. For standard conservative treatments, most of the patients who are seeing us, they may have already gotten some oral anti-inflammatories or had a corticosteroid injection. Certainly for those who are getting referred over, hopefully those were ultrasound guided, so we know really where that was. It seems like the trochanteric bursa injections are easy to do, but after you watch them under ultrasound, you understand how specific that injection needs to be to get a good response or an accurate response, and then also make sure that it was not intratendinous. So these are peritendinous intrabursal injections, and we'll talk about diagnostic use of injections for the hamstring as well. For physical therapy, if the patient hasn't had therapy, we're certainly going to address it because anyone who's coming in with significant greater trochanteric pain in gluteal tendinopathy, they're going to have some gluteal atrophy, specifically in that glute med, and working on gluteal control, core to the floor type of exercise, and then trying to load into some eccentrics with pain modulation can be helpful. Instrument-assisted soft tissue mobilization can be helpful, especially if the patient's having gluteal tendinopathy with significant IT band pain, and their pain is more superior to inferior versus posterior to anterior type of gluteal pain. That can be helpful. Dry needling, just making sure that no one's getting into the tendon as much as they're needling the muscle to relax that. Certainly for people who have significant muscle atrophy of the glute, sometimes that can help to take out some of the spasm and get them going through physical therapy a little bit more. And neuromuscular electric stimulation, whether it's in PT or there's some of the wearable devices that patients can get, anything that can help control the glutes are going to be helpful to get those as strong as possible prior to doing the procedure. You know, some patients are so painful that they just don't tolerate anything, and TenJet's the first step. But in any area of the body, if you can focus some good physical therapy around the glutes and the core prior to doing it, anecdotally, that makes for a happier patient afterwards and a lot less phone calls as well. Getting ultrasounds early, as soon as a patient presents with gluteal tendinopathy or hamstring, ultrasound's my go-to. Do it in the office and also order a full diagnostic evaluation by our musculoskeletal radiologist. And as we've talked in previous talks around the type of tendons that we approach with TenJet, it's that type 3, type 4, that area of tendon that has true degenerative mucinous degeneration of the tendon tissue, where it's swelling the tendon, causing that tendon to become thickened. And this is why it hurts. This is why it hurts when they sit for a prolonged time with the hamstring tendon, and also why they lay on it in bed and it hurts. Spending just a little bit of time with ischiofemoral impingement for a review if you're not familiar with this. So looking at an MRI, many patients, especially with significant hip pain, end up having an MRI before we end up seeing them. We're looking at the hamstring tendon origin there, you know, scrolling up and taking a look at piriformis, very common for us to do, right? You're looking at the neurovascular bundle that's up in front of it and seeing if there's any issues there. And on an MRI, a lot of times we just kind of sweep through this, right? Like we get up to the piriformis, swing back through, see the hamstring, and then kind of miss some of the things that are in between. But there is a glaring, very significant pathology that we can see on here. So on the side here, we have the lesser tuberosity. Lesser trochanter in the ischial tuberosity, and the space between that is that ischiofemoral space. The muscle that slings over kind of like a hammock there is the quad femoris, and that quad femoris muscle can get pinched between those two areas. So you can see on the right side here, all of this white area, that's all atrophy. So that's an incredibly atrophied quad fem muscle because it's continuously getting pinched between that ischial tuberosity, this thickened tendon from the hamstring origin, and then pinching into the lesser trochanter of the hip. So something that's we can pass by really easily, but something that's also easy to see if you know what you're looking for. So don't get too focused just into that tendon. Make sure you're looking at that quad fem. But even if you are, what do you do with it? Well, ultrasound, you can see this as well, right? So we're looking this in transverse from axial plane kind of standpoint, the ischial tuberosity here with the hamstring up over the top, lesser trochanter here, and we're looking to see what that space is. So that space should be about 2 centimeters. If it's more narrow than that, you got to look and think maybe the hamstring isn't causing that issue. And probably one of the easiest things to do is intrabursal injection. So we're looking you know, transverse in-plane injecting into this bursa, even if it's just diagnostic. This is not something that is going to help ischiofemoral impingement. It's something that's going to help their tendinopathy of their hamstring, even if it's just a diagnostic lidocaine injection. Now, patients can present with both conditions at the same time, but at least this helps diagnostically. And I will tell you, the number of patients that I do a diagnostic injection around their hamstring has been helpful in figuring this out. 2 tests you can do to identify the difference. One is this long stride gait test. So you're intentionally having the patient leave that leg back, let it lag, versus this normal kind of gait that we normally look at with them. The positive test is when they're letting that leg lag and they're having this long kind of stride, they're getting pain you know, lateral to the ischial tuberosity, right around the area of that sciatic nerve, in between that lesser trochanter. And then you have them walk with a shorter gait and their pain goes away. Very similar from a functional from a functional standpoint, that's the best way to do it. From a passive standpoint, you know, you grab the patient underneath their knee, you extend their hip back, and so what you're trying to do is you're trying to directly impinge that lesser trochanter right into the ischial tuberosity. And if they get pain there, then you abduct them about 20 degrees and see if it relieves. If it relieves, that means that you're no longer pinching that ischiofemoral space, so that's a more positive test. And for a patient who hurts directly on the ischial tuberosity and has positive tests like this, that is a patient that I would do a diagnostic ischial bursa injection to try to see if we can make all their pain go away. If all of their pain relieved after that injection, I'm confident moving forward with TenJet. If a good amount of their pain still is there, that's where I might use some of my musculoskeletal radiologists, or we may do an ischiofemoral space injection. So again, it's probably one of those conditions that sees you more than you see it. And I will tell you just from personal experience, the amount of times that I ended up doing a TenJet and the patient still had some pain because I didn't take enough time to really take a look at that. So that's now part of my protocol. So probably one of the best maybe pearl takeaways from this talk. Getting into the procedure and how we set this up, the room and tray setup that we have. Normally I'll use a 21 gauge 2-inch needle. I might use a spinal needle, but if I know if I can reach it with a 2-inch, I'm going to be able to reach it with the TenJet device and then some. The procedure tray as it's set up, again, important of just using an 11 blade. Don't need anything larger than that small little stab incision, and then you let the device get down into the tendon and do its work. Important thing to take away, especially for glutes and hamstrings, is to have an additional pillow. I'm going to show you some of the setup for patient positioning, and having this a patient in a position of comfort is going to be important for this, because they're going to be there for a little bit, right, as we're prepping and getting to the area, and certainly as you're getting through multiple planes of fascia, and for some patients who have a little bit more adipose tissue, as you're getting through each one of those planes and the patient feels that little pop, even though it's not painful, it can be a little bit jarring. You got to get them back into a position. So making sure that they're comfortable is important. This is the positioning for all hamstrings and all gluteal tendons that I do in the office, and we'll explain with a couple of images why we do it this way. So either the patient is lateral side lying, we'll give them another pillow underneath their arm there that they can kind of hug, and then just bringing their leg up just enough to put a little bit of tension onto the glute med, and then the same thing over with the knee to chest with the hamstring. You see a lot of hamstring evaluations being done as the patient is prone. I did a lot of minimally invasive tenotomy on patients who were prone, and I'll tell you, it's hard. The tissue moves a lot. You got to get through, especially if you're getting down where the gluteal fold is and trying to come inferior to superior. You're going to get lost. You're going to get lost, and it's hard to kind of get everything in line. So going in a position where the patient is knee to chest, you're pulling tightness across the gluteal area. You're putting all of those tissues on tension. And I will tell you, coming from a superior to inferior longitudinal in-plane approach for the hamstring absolutely has changed how I've approached my injections and the comfort that the patients had and the comfort I've had in doing this procedure. So when we look at gluteal tendinopathy, very common way of approaching this is from anterior to posterior. So you're doing a transverse in-plane approach in the TenJet procedure, minimally invasive tenotomy procedures being done down there on the bottom image as we're going across that tendon. I would approach the procedure this way if the patient was telling me that they were having more of that posterior to anterior greater trochanteric pain. And if you've seen enough patients who come in with trochanteric bursal type of diagnosis, you'll see that some of them will hurt more superior to inferior along their IT bands, and other ones will hurt more posterior to anterior. I will tell you that that's the last thing I ask the patient before we're getting ready to anesthetize or set up is, most recently, what direction have you been hurting? And I will tell you, this is completely anecdotal, but I have noticed an improvement in those outcomes by approaching it this way, because you're either going a little bit more in line with some of the glute max that's coming around and making that glute max back of the IT band type of syndrome, with the medius not being as significant, versus the glute medius truly giving more of that superior to inferior. So here's the other look at that superior to inferior longitudinal in plane. Again, here you're seeing that facet of the greater trochanter here and coming down into the glute med. Finally, with the hamstring tendon, again, this top image looking at that supine. Again, if you think about where you are there and being able to get up into an area that you can see it in longitudinal, the question is, where's your needle? Right, so I mean, if you're going to come in through this way, some docs I know will go transverse and come from the side. I get concerns about the sciatic nerve there. Essentially, I'll have the probe in this orientation, but I have the patient in a lateral recumbent. So as the probe is longitudinal to the tendon, I actually come in just above. I come above the tendon coming in right through here. Ischiotuberosity is over the top. I know my sciatic nerve is lateral to this because I look at it before coming in. I have a very short distance to get through to get into the tendon, and I'm still longitudinal. Much easier than trying to come inferior to superior. I can get in, I can get around the bursa, and I can get into the tendon right at its insertion. So the way I do my diagnostic injections, in addition to approaching it this way, I felt much more comfortable, and I enjoy seeing hamstring patients more because I feel like I have something that I feel even more comfortable approaching from a diagnostic and a therapeutic standpoint. Finally is, the motion of this, and we've spoken about this in other webinars. This isn't a magic wand. This doesn't just go in and do all of the work, by it being inserted in there. It is very effective at resecting and removing the tissue that comes into contact with this cutting window and the suction that brings that tissue in towards here. But it doesn't get to that tissue on its own. You have to bring it there. And so that's where the pistoning type of technique, where you're inserting and removing in small, sub-millimeter ways, you can kind of see the way that we do it here and again into the hamstring. And then the rotational, kind of up at the top, where we're pistoning back and forth, but we're also spinning that device in our hand and turning it up and changing the direction of that cutting window. You want to think about accessing all of those areas of tendinosis. So I think early on, people have felt, kind of they put it into the tendon and they kind of move it around in the tendon, and you end up feeling much more comfortable being a little bit more aggressive with the device because you have to get to the areas of tendinosis. And so it's not being over aggressive to any of the tissue, it's using enough force to actively get to the tendinosis so that the device can do what it is. So you rely on the device to have that suction and that ability to resect and remove, rely on yourself for being able to get it there. And I would say that the outcomes will follow along with your ability of feeling that tissue and feeling comfortable getting into that tendinotic tissue. So takeaway pearls outside of what we've just talked about, training is a must, right? If you don't already feel comfortable, especially in the gluteal area, especially in the hamstring area, doing a peritendinous injection, start with a different area of the body that you feel more comfortable doing ultrasound guidance. If you don't have any ultrasound guidance experience, plenty of training that you can get around the country and feeling comfortable with it. You probably need about 100, 150 evaluations and probably ultrasound guided injections until you start feeling really facile. You feel really good up until the patient moves about 2 or 3 inches and readjusts, and then you got to know where to go and how to get it into that area. So probably dealing with enough of those to feel comfortable, especially when you get into the hip area and to do it with efficiency. We talked about the fact that type 3, type 4 tendons are the tendons that we approach with this. Patients who have significant hyperemia, I mean like the hamstrings where the entire bursa is inflamed, the tendon's inflamed, it's actually inflamed down in the musculotendinous junction, things that have longitudinal split tears, calcific tendinopathy that we see at the greater trochanter and the ischiotuberosity. You can let patients know whatever you typically are seeing in your office as anecdotally how patients are returning and how soon they're better. Add 4 to 8 weeks on that, and I'd probably lean into that 8-week mark. Somebody comes in with longitudinal split tears to the hamstring tendon, not anything transverse, but longitudinal split tears, significant hyperemia and calcific tendinopathy. I'll tell them that it's going to be 5 to 6 months before they're to the point where they really are able to pass judgment on this, because they've compensated for so long that they probably do have some component of ischio-femoral impingement. They're loading their back differently. It's not the fact that it's going to take that long for the tissue to heal and for the procedure to be successful, it may take them that long to get everything else in concert working together to really feel the relief of their back and their leg and their lateral hip, not just around sitting down in a car. If you're using corticosteroid injections in these areas, and certainly I do as well, not only from a diagnostic standpoint, but from a therapeutic standpoint to try to get the patient through physical therapy and get them as strong as possible prior to, remember that you're going to want to wait about 10 to 12 weeks. One, for the steroid to no longer have any effect, and two, to really see how they were able to do with physical therapy. In our office, no one's getting the steroid injection unless they're going to be doing some therapy, because it's a means to an end, not a treatment all along on its own, but you should wait a while before going in with TenJet. Separate procedure day for doing this is key, making sure that you have enough time to do this, especially when you're starting to get into hips and glutes, anesthetizing the area well enough that the patient's not having any significant pain, and potentially even needing to re-anesthetize if there is still a little bit of pain as you're working through the tissue. You don't want to be rushed in between procedures in order to do this. You definitely want to work closely with your orthopedic surgical colleagues. If you're not an orthopedic surgeon who's doing this, if you're sports medicine doc, PM&R doc, interventional radiologists who are doing these, and the physical therapy group, staying in close touch with them. One thing that we talk about, anytime you take a needle, the hydraulic pressure of that needle and injection is delineating and dividing tissue. It's causing a hydrodissection. So a couple of things to be aware of is, one, that's a massively powerful tool to breaking up any scarring between fascial planes, and also it can cause damage, right? So anything that you put into a body area and you put that kind of pressure, you can cause that damage. Now, you can't cause that damage with the TenJet device, but be careful when you're anesthetizing tendons that you're not overloading the tendon with fluid. You're putting small aliquots of anesthetic into the tendon to anesthetize it, not to cause any dissection or damage of the true good tendon fibers that are there. Probably some of the best takeaways that I can give with that. Thank you very much. And hopefully you have a similar experience that I've had in seeing how this has been able to change a large number of patients that we have in our offices with gluteal and hamstring tendinopathy.